My parents were products of the greatest generation. They were that generation. But they also suffered the trials and tribulations. My father actually never went to high school. And my mother did finish high school, and only later in life, when I was in medical school, did she get a college degree. But that being said, I think I owe so much to the fact that they were deeply spiritual people, really committed to their faith. And at the same time, they were people of incredible integrity with a strong work ethic. And they understood the value of education, that not just what it could do for an individual personally in terms of their job or their income prospects, but the doors it would open, the opportunities. And in their view, those opportunities weren't for me or my brothers. Those were to make this a better world, just as they'd worked hard to do. So my brothers and I were the first in our extended family to go to college. I don't know what they really believed. They often said they wanted at least one of us to become a Lutheran minister. That did not occur. But they gave us a great sense of curiosity around education. So through a set of circumstances, I ended up in medicine. I have a brother-in-law and one who's a biomedical engineer and researcher. So we each found our path. For me, as a child and now decades later, there's no place I'd rather be than the mountains. And other than their obvious beauty, I think there's something about being in spaces that are so incredible, so massive, in some ways so wild, that humbles you and gives you a sense of that each of us occupies just one small place in this big, wide, wonderful world. And I think it also instills a sense of self-reliance. And while it fosters some of your individual self-reliance, it also gives you a sense of being accountable to the world. That something that's so big and so beautiful, we really do have an obligation to treasure it and be a good steward. I wish I could say that I left college to go to the mountains to find myself, that it was something that poetic or mystical. I was a college student who wasn't sure about what he wanted to do, who was very short on the financial end, and really stumbled upon a very well-paying job as a surveyor in the mountains. And while I was a liberal arts student, liberal arts major, I didn't imagine that as being my career. I imagined it just as foundational to something else. I wasn't sure what that something else would be. What occurred to me was truly, truly terrible and tragic for the people involved. We were near the Continental Divide, near the tunnel being built through the Continental Divide, on a beautiful fall day, a day that is as gorgeous as any day in the mountains of Colorado can be in October. A plane flew low overhead, and as we were following it and talking among ourselves on the crew about how low it seemed, it rapidly lost height, pancaked into the mountain, and exploded. And by virtue of where we were the first people on the site. There were some survivors, even some ultimate survivors, although some of those who survived the crash died shortly after. And in hindsight, I think it was the juxtaposition of the kind of perfect beauty of the day and the awful human tragedy of the crash and the injuries and death that I saw that gave me this sense that life can be beautiful and it can be very serious indeed, and that on the serious side you should find something meaningful to do with whatever gifts you've been given, and that in itself can involve a kind of beauty. And so as much as there's any turning point for any individual, that was the day I decided I would become a pre-med student. And I returned to my job and finished the contract and then went back to school as a pre-med. For financial and other reasons, and in order to have the ability to take evening classes to continue to work, I attended what was then called an extension of the University of Colorado. That was really a charitable term for a satellite campus that was for commuter, mainly working students. And I was, at that point, I was both completing my studies in my major, philosophy, but also pursuing pre-med courses. And the teaching there was as student-centered and as fantastic as I think I could have gotten anywhere. And although I wasn't really viewing it that way at the time, I think what it was an example of just how great public higher education in America is and how central it's been to our success as a nation. And what a disservice we would do ourselves to imagine that superior education only occurs in limited venues. I came to believe that education is a product of the combined passion of a teacher and a learner, and that can happen anywhere, any college, any emergency room, any bedside, any clinic in the country. I had never considered a career in research, and I was, again, just extraordinarily fortunate to be blessed with someone who was a mentor when I didn't even understand what a mentor was. And this was a very junior faculty member who took me under his wing during my psychiatry residency. I was interested in mental disorders, and I saw myself as having a career treating them. He opened the door to me to realize the excitement of discovery. And he was so passionate about it, it infected me, and I became very interested with it. And that was really the gateway then to my career at NIH and subsequently to my career as a research dean. I could have easily been, and would like to believe that I would have been a very capable practitioner out on the front lines, but these other opportunities came along. In part because his interest in the broad range of neuropsychiatry, his interest was on schizophrenia, and some of the early research work I did involved those patients. It gave me, I believe, a particular perspective on research. There is enormous value, and there's real joy in bench laboratory discovery. But when you think about the spectrum of human illness, schizophrenia is arguably one of potentially the most devastating diseases. Typically striking an individual, many individuals who've been very high functioning, striking them in late adolescence, robbing them of their ability in some cases to think clearly, in some cases to know what's real and what isn't real, in some cases to trust their very senses. Is that a real voice talking to me, or is that an hallucination? Not only can it be devastating in terms of the symptoms, but it can last for decades. In the thankfully increasingly small number of patients with schizophrenia who are treatment resistant, this can become a lifelong task for them and for the people who love them and care for them. And when you see an illness that creates such a burden for the individual and such a burden for their family and their friends, it adds a whole new dimension to research. It makes you feel, in some cases, almost desperate to gain ground in understanding and treating their illness. But another element of it that I think we appreciate more and more every day in the research community is it makes them very vulnerable. And it gives us an even higher ethical obligation to protect them in the course of our studies from their vulnerabilities. I saw this play out in so many ways early on. There is value in being able to conduct some studies or laboratory tests on a patient with schizophrenia when you don't have the interference of their medication. On the other hand, there's a real risk to a patient asking them to come off their medication. I would argue that my happening to pursue schizophrenia research actually gave me a window on what are some of the greatest dilemmas of our time around integrity and ethics in research. And so it was that early experience that not only shaped me, but I think helped me understand in every area of research that balance between the quest for discovery, the joy of discovery, and our obligation above all to do no harm. We want ultimately through research to do good, but we have to be realistic that every research project entails potentially some element of harm that we need to scrupulously avoid. I believe that there is a kind of ethical reawakening in the medical and medical research community. And I actually believe that the reason for that happening, there are multiple reasons, but one of them is we're at a real crossroads in our nation. We've just experienced the worst economic threat to occur since the Great Depression. We have come to the conclusion finally that it is not just unsustainable, but it's intolerable to spend more on health care than any other nation, but not have outcomes that match it. And there's a growing will to change that, to not just accept it. I think we went through too many years as these problems were building when people said, my obligation is to the task in front of me, whether it's the patient scheduled that day or the research study at hand, and assuming that somebody else would take care of these larger issues of a system not working fairly for everybody. And I increasingly am inspired by my colleagues out there who remember that one of the core tenets of medical ethics is social justice. And that having a healthcare system that doesn't work for everybody, having important research questions that get neglected because there's no financial incentive, that all of those ultimately are tantamount to ethical lapses on our part, and we shouldn't tolerate them, but that we should do our very best to correct them. There are some real inspiring leaders around this country who understand that and are taking very practical steps to change that. I just view my job here at the AAMC as being their biggest fan and trying to communicate coherently about what that growing will is and support it in any way we possibly can as this association here inside the Beltway. I think it's like any other form of social change. You have some people who are, to use the phrase, early adopters. We have more than I would like. We have people who are in a kind of wait-and-see stance. And then we also have just the psychological reality that change is very hard. And I see many physicians of my generation who came up professionally in a world, it was familiar to them. They may not have been happy or satisfied with the way everything worked, but it's the world they knew. And they don't have a tremendous sense of energy to lead that change. I understand that. What gives me great encouragement is looking at the next generation. Everything from the people I meet applying to medical school to the junior faculty members I encounter out on campuses. Their appetite for change is much greater than I think any of us are acknowledging. And when they're given the chance, whether it's to participate in a research ethics committee or to drive changing the clinical delivery program in their institution. They seize the opportunity. And I think that's exactly the energy that they need. And the job of my generation, I think, is to get out of their way, to really empower them to push that change forward so that we don't become the obstacle. We have our annual meeting coming up, and I've been working on my talk for that meeting. And this builds on not just things I've said, but things other leaders have said in various AAMC venues. And rather than view it as a list of questions, I'm conceptualizing where we really are as a moment of truth. So if I'm a medical school dean and I look at the distribution of the students coming in and I look at how disproportionately they're clustered in the highest socioeconomic group, I look at how debt burdened they are when they graduate, that creates a moment of truth. Do I continue to push tuition to the very edge, knowing that it decreases access for some students and it burdens almost all of them with debt? Or do I say, no, my priority is to really control my tuition increases and to get out there and raise money for scholarships as actively as I raise money for buildings? If I'm a hospital CEO, the moment of truth comes when do I focus what little capital we have to invest? Do I simply say, well, we'll invest it where in this current fee-for-service system we can make the highest margin? Or do I invest it where our community health need is greatest? In most cases, those are different things. And it's, do I have the courage with the people working for me and the board I'm accountable to describe that for them, describe that dilemma and make the right choice, the choice with ethical integrity. I think investigators are faced with this. Am I asking the right questions, or am I simply following the grant money? Am I really paying attention to how vulnerable my research subjects are in the course of this, my study, and doing everything within my power to protect them? So it's these moments of truth. I don't think there are just 5 questions. I think there are hundreds and hundreds of questions that we all encounter every day. And the more we treat each one as a small, perhaps seemingly tiny, individual moment of truth, not only frame the question, but answer it with integrity, the better off we'll be. That may be one of the areas where in my 7 years here I've seen the biggest change. I can't say enough about the courage my predecessor, Dr. Cohen, showed in putting this issue front and center, because we weren't paying enough attention to those entanglements and how they could potentially distort our work. He really got the issue on the front burner. When I arrived, unfortunately, it seemed as if the world had split into 2 camps. One was that there is no way you can have any relationship between industry or any for-profit enterprise and your own research studies. And the other camp that essentially said, advocated a laissez-faire position. You know, we're good people, we'll sort it out, trust us. I give so much credit and have so much praise for Ann Bonham, my colleague as Chief Scientific Officer here. Her use of the phrase principled partnerships, and not just her use of the phrase, but her showing people the nuts and bolts of what that means, of how you can have a partnership, you can attain some synergies, but you can do it following principles that ensure that those distortions do not occur, now is being more and more widely adopted. And I think people aren't feeling that the partnerships should just be given free rein, and they aren't saying no partnerships are possible. They're but once again, asking the right questions about each partnership and the aspects of it, and balancing any of the risks versus the benefits in a much more clear-headed and explicit way. It's quite a change, because I don't now see people fighting the kind of simple-minded battle of no relationship, unfettered relationships. What I see people is being ethically attentive to each and every partnership to ensure that it meets the standards we all want to adhere to. The best part of that is I feel like we're regaining some of the trust we unfortunately may have lost during those years when we were confused about this and first starting to deal with it. I was primed even before I decided to go to medical school. As I mentioned earlier in our conversation, I was a philosophy major, but I will confess at this point in my life that the only part of philosophy I really understood was ethics. Things like metaphysics and epistemology baffled me a bit. But the ethics I understood, and I admired its clarity and simplicity. And I also came to understand that ethics in theory are very different than ethics applied to the real world and the dilemmas you have to face. Then when I got to medical school and took an early elective in medical ethics, I saw that even more clearly because of the dilemmas that are posed in the course of clinical care research, and how the theory is one thing, but the practice is another. I feel that as a profession, nobody enters, in my view, medicine without feeling some sense of ethical commitment to the patients that they're going to take on and the like. But I think we've lapsed into a kind of presumption. I took the Hippocratic Oath, therefore I must be an ethical person. And what we didn't do enough of was teaching our learners that no, it's only the application of your ethics that are the test, and that test happens every day, many times a day often, in terms of what action you actually take. Both in the coursework I see, but especially the kinds of activities at our schools and in residencies of real-world ethics conferences, of periodic debriefings about things that the students or the residents have encountered on the clinical their clinical situations, or in scientific laboratories. Regular confrontations of what are the ethical issues that are coming up in our work. That we're taking people from that misperception that we have a degree, we took an oath, therefore we are ethical, to saying no. The test of our ethics is these day-to-day questions we're confronted with and answered. I have a daughter who's a third grade teacher, and as I've had the privilege of visiting her classroom and seeing her skills at dealing with questions of values, I agree that there's a lot of work that's done foundationally very early in the family and in the schools, in your educational process. On the other hand, I think it's also a mistake to somehow believe that those things then are hardened and fixed, and that the proper application of those values is guaranteed. Sadly, as a medical school dean and as an academic teaching hospital leader, I encountered many people who I think had very solid values, but who had serious ethical lapses. And in part, I think it was this presumption that I learned that all then, therefore everything now will be fine. What we need to do in our profession, in medicine, in research, is have more explicit discussions. You know, if we talked about our values and the application of our ethics 1/100th of the amount of time we talk about our budgets, it would be a much richer environment. Virtually every campus I visit has established, some of them call it an academy of educators, or an institute for education. And basically it's a way of supporting, aggregating some of their most active and their best teachers. And when I meet these people, when I learn about how they select people, it's much less what they can do in the formal curriculum, how much anatomy can they teach, or how many pharmacologic principles can they convey. It's what they do in the informal curriculum. It's the behavior they model. It's the way they apply ethics in the laboratory or in the clinic. I think we're recognizing the value of that, and even more importantly, we're rewarding that, because we're in challenging financial times. We will get what we reward. If we reward mentoring and positive role modeling, it will continue to flourish even more in our schools.
So you just showed up to N Street in 2006. What were some of the goals you set when you first arrived, for your tenure and stewardship of the AAMC?
I'm not being facetious when I say my major immediate task was learning all the acronyms. We're an organization with more acronyms than any organization on the planet. But once my head stopped spinning around those things, given the time, we hadn't encountered the financial downturn, but there was growing discussion about the unsustainability of the healthcare system. To put it in simplest terms, I came to an organization where I felt we faced a fundamental question. Our healthcare system wasn't working the way we needed it to, and it was breaking the bank for us as a nation. Were medical schools and teaching hospitals going to somehow deepen that problem, or were we going to be key elements in solving the problem? For me, that was the key question. And would all of our efforts, not just in clinical care, but in education and in research, be focused on that? So could we shift our education away from traditional standardized testing to more lifelong learning and competency? And in research, could we have just as much vigor in our institutions in terms of studying the science of healthcare delivery and what works as we have had in studying the genome? So it was, in all our missions, can we turn ourselves to being the solution to this national problem, this mismatch between the precious resources we spend and the outcomes that, in many cases, sadden me.
And what have been the greatest barriers to achieving that goal, objective, or at least that very idealistic desire to be more proactive in solving it?
This is big change. Yeah, I think that one of the barriers is our natural aversion to change as human beings. And that's whether you're a patient who expects the latest drug that you saw on TV last night, or you're a physician who is perhaps too susceptible to the last pharmaceutical company representative they talked with. So all of us have changes we've had to make. That's, in some ways, I think, the biggest obstacle. But a more specific one is, I think we are in the year 2013, we are unfortunately have lapsed into a deeply, deeply polarized social situation in the United States, where we've taken up sides on issues, almost every issue, and we're unable to find our common ground and move forward, and it's leading to enormous inaction. This isn't a statement of political affiliation. I think it's a statement of reality. We need an effective government, and it needs to reflect some kind of effective social consensus if we're going to thrive as a nation. And right now we don't have that. What will have the longest and most important impact? I'll choose one thing from each mission. Although it sounds small, on the education mission, the process we've gone through to in many ways change the MCAT, the medical college admission test in a greater way than it ever has, I think sends a signal that will reverberate throughout the profession. Because by acknowledging that it isn't just your competence in biology and physics and chemistry, but by placing equal weight on the social and behavioral sciences, by emphasizing tests of critical thinking, we're sending a clear message to anyone who might consider being a doctor of what kind of person we need and want in medicine now. You know, unfortunately, we had gotten to the point where too many bright young people assumed that the question about whether they should be a doctor was whether they loved organic chemistry. Chemistry is important, but it's not all there is to the profession. So that's on the education side. On the clinical side, it is the growing commitment among our members to design solutions to the healthcare system, ones that improve outcomes while containing cost. We have learning communities growing all the time around ways we can do that, and that will result in better quality and safety in the clinical setting. And on the research side, I wish I could say it was renewing our national investment in research. Unfortunately, our funding for research has remained stagnant. But I do believe something we discussed earlier, this sense that if we establish principled partnerships, we can harness the power of lots of industries as well as the minds in our academic institutions while protecting our patients at the highest level. So I would say those three are the things that the AAMC has done in the last few years that I think may leave a lasting mark.